Good morning, everyone. My name is Natalie Fanny Gonzalez. Today is June 30th. Welcome back to the County Council session. Before we begin, I'm going to ask everyone to see if you can please take a moment of silence. Oh, no, it's going to happen. As you all know, my family is from Caracas, and it has been quite the tragic few days, and a reminder that anything can change in people's lives in a matter of seconds. And I'm blessed that both of my brothers who live in Caracas, they're saved, as well as their family, but thousands of people are still missing. Thousands have died. Even little children. The other day I found out that a little league of baseball team, kids who were 10, 11 years old, all died. And it's just a reminder that at the end of the day, whatever we do here, we need to hold on to our humanity and ensure that we do things because we care about this world. And we need to remind the people who are with us that we love them. And it has been really amazing to see the worldwide love that they have for our communities, and seeing so many people from across the world arriving in Venezuela just to help. And including people from the Washington, D.C. region, local restaurants, sending supplies, and I felt like I had to say that. If you guys are okay, if we can take a minute, that would be great. And with that, I thank you all. And we're going to begin with general business. Are there any announcements?
Thank you, Madam President. Good morning. Today, Council Members Balcom and Sales are attending this meeting virtually. Thank you, Madam President.
Thank you very much. And we have the minutes from May 12th and 13th, 2026. Council sessions, May 14th, 2026 by county budget session, and May 14th, 15th, 21, and June 9, 2026. Council sessions have been circulated to the council for review. Are there any? Are there any objections to approve this minute? Seeing none, these minutes are approved. Give me a second. And now the council will now sit as the Board of Health for the biannual updates. If we can have everybody from this item come forward. And I'm gonna ask council staff to please take it away. And as always, Q&A will be at the end.
Good morning, Council President and all council members. We are sitting as the Board of Health as required by the state of Maryland. The county has to sit as the Board of Health twice a year. It is recommended May and October, but we know May is an intense month for us. So usually we meet in June, and we will have our secondary meeting in October. I want to thank, excuse me, I want to thank Dr. Keisha Davis and her team for organizing the slides and providing all the information and coordinating with us. And with that, I will delve into the presentation. We will, if the council members would like, we can send the presentation to you after we are completed. And thank you so much.
Good morning. Council President Fanny Gonzalez, we share your empathy and concern and prayers for folks who in Venezuela. So thank you for reminding us of the empathy and humanity that exists among all of us. This is our biannual Board of Health update. We have a marathon of information to cover. We probably won't get through all of it, and so if y'all want to say stop anytime, we can stop. The first four on the left, I think, are the most important, and then there are general updates of things that I'm sure all of you are also very interested in, so we will get to those as well. We'll start off by reviewing the epidemiological changes that we are seeing in the county. We will review our county health improvement plan, Medicaid updates, behavioral health, and then we will go into some general updates around a number of different topics. Okay, so for our epidemiological data, we are seeing population changes in Montgomery County. So Montgomery County has now passed 1.08 million residents, and it is rapidly becoming more diverse. This is not a surprise. Between 2020 and 2024, non-Hispanic white residents, yes, decreased by 5.8%, while Hispanic residents increased by 1.7%. Most of the population increase that we have seen is due to increase in numbers of Hispanic residents. Also important to note that the over 65 cohort grew to 18%. This is a record. And we've seen population decreases in those younger age groups. Also interesting to note where the population is growing. So we've seen the greatest growth in 20842 and 20871, Dickerson and Clarksburg, and surprisingly the greatest decrease in 20899 and 20868 portions of Gaithersburg and Spencerville. We also look at the leading causes of death in Montgomery County from 2021 to 2023. Again, remind you that when we're looking at epidemiological data, it is typically delayed. So the latest information that we have is from 2023. But you can really see the recession of COVID, heart disease, cancer, cerebral vascular disease, which is stroke, diabetes, chronic respiratory disease, taking their places again as the top leading causes of death. And they are chronic diseases. And so you can almost think of COVID as the tide that was coming in and covering all these things. Now that tide has come back out, and we are back left with those chronic diseases that are harder to treat and require more sustained emphasis. Next slide. I also want to note changes in food insecurity. When we look at going back to 2019, that food insecurity rate of 8.6%, as emergency federal programs really helped insulate Montgomery County residents from hunger. And although those pandemic era food aid has ended, food insecurity now exceeds pre-pandemic baseline levels. You see us now at that 12%. Again, this is in 2023. And while Montgomery County remains lower than Maryland at 13% and the United States at 14%, it is still noteworthy that we are above where we used to be. I want to highlight some of the work that we do with Office of Food Systems Resilience and the work that they have been doing to help address this problem. Several programs that they have awarded 6 organizations through their Food as Medicine grant to health clinics and hospital systems throughout the county. In that Food as Medicine grant, they identify patients with health needs who are also food insecure and provide them with access to fresh fruits and vegetables with dignity. So they allow them to shop for foods that are specific to them and their culture, as opposed to just giving them a standard box. So they are able to tailor the meals that are most appropriate for them. There's community food assistance and school-based food assistance programs, which support organizations that distribute food to residents through community distribution, prepared meals, market voucher programs that occur on a recurring basis, as well as the nutrition benefits outreach grantees who collaborate with food assistance provider networks, schools, and community services to offer application and enrollment assistance for programs including SNAP, WIC, Sunbucks, and other benefits programs. And then I also like to highlight the MC Groceries program, which currently supports about 500 county households that fall into the self-sufficiency gap. So those are folks who don't quite qualify for SNAP, but we know living in Montgomery County is expensive and they don't quite meet that self-sufficiency standard. And so they get a grocery stipend of $100 to $400 a month that they can use on Instacart to obtain groceries, healthy groceries. And so this is really important. You know, when we go back to the previous slide and we talk about chronic disease, diabetes, hypertension, and the things that we need to do to help support them, we know that food is a big part of that picture. And so applaud the Office of Food Systems Resilience for these programs. And we know that this is an important piece of the puzzle as we start to tackle chronic disease. I want to shift gears here a little bit and talk about Healthy Montgomery and our Community Health Improvement Plan. So the Community Health Improvement Plan is we do this every 3 years. It is based on the Community Health Needs Assessment, and it is conducted by a group called Healthy Montgomery. Healthy Montgomery is the Montgomery County's local health improvement coalition. The state requires every county to have a local health improvement coalition, and it really is a coming together of government, private sector, public sector, community organizations focused on the health of the county. It is always co-chaired by the health center, by the health officer, and a community representative. In this case, it is Kimberly McBride, who's the Regional Vice President of Community Health and Wellbeing for Trinity Health Mid-Atlantic, also affiliated with Holy Cross. So Healthy Montgomery, as I mentioned, the purpose is really to inform, advise, and ensure implementation of the community health improvement process for the county. As I mentioned, we serve as a local health improvement coalition. And this work is achieved through leading, planning, and implementation of the Community Health Needs Assessment and the collective creation and implementation of the Health Improvement Plan. With that, I will turn it over to Kimberly McBride to talk a little bit about the collaboration.
Thank you, Dr. Davis. So before we really get into the details of the process, I really wanted to take a moment to ground us in the depth and longevity of Healthy Montgomery. This isn't a new initiative. Healthy Montgomery has been in place for almost 2 decades. And over that time, it's really evolved into a mature, well-established community health improvement effort. As a big part of that longevity has been the consistent partnership that we've had with our hospital systems. So since 2009, hospitals have actively engaged in the governance, the planning, and as members of the Healthy Montgomery Steering Committee. And importantly, they back that commitment with sustained investment, supporting the infrastructure and process that allows the work to happen. Over that time, the partnership has evolved, such as in 2015, the hospitals came together to really discuss, community benefit, leveraging resources, and really making sure that the hospitals themselves weren't duplicating efforts. And through that partnership, it has resulted in a joint CHNA and CHIP in 2022 and 2025. And while the county conducted its own CHNA through DHHS, from there, we really took an important step forward, coming together to develop a joint community health improvement plan. So aligning strategies across the hospitals and the county. So what you're really seeing is a progression from coordination to alignment to really true integration. And so all through that collaboration, it was made possible by Healthy Montgomery. And at that experience allows us to be more coordinated and ultimately have greater impact on community health. Next slide. And that longstanding partnership, especially with our hospitals and cross-sector partners, is exactly what the Healthy Montgomery structure is designed to support. So this slide really brings to life showing how we've translated years of collaboration into a governance model that keeps everyone aligned and moving in the same direction. The structure reflects that what we've learned over time, that improving community health requires shared leadership and coordination across sectors. The steering committee includes 2 members, required members, which are on your left, and then term members on the right. Required members include key county agencies, local health systems, and really core community initiatives. So that these are the partners that are consistently at the table because their community health is so broad. In addition, term members join for defined periods to bring additional expertise and community connection. This balance really allows us to maintain continuity while also bring perspectives. For instance, myself, who's been on the steering committee since 2009, sometimes I have blinders on because I think of how things tend to go. That new perspective really brings a new, fresh set of eyes to really make changes that we may not have thought about for the longstanding members. So it's a really important aspect. The committee is also led by 2 co-chairs, one from the county's Department of Health and Human Services and one from a partner organization. The model is really intentional because it reinforces that this is a shared leadership not owned by any one entity. So instead of fragmented efforts, we have really shared the set of the table with shared priorities, shared decisions, and shared resources where we really align and drive what real coordinated impact means. Next slide.
Just to talk a little bit about what the CHIP is, and I want to highlight here the partnership that is happening between DHHS and the hospitals. We are doing the CHIP in a different way that we've ever done before. Typically, the hospitals have to do a community health needs assessment and their own community health improvement plan, and DHHS has to do a needs assessment and an improvement plan, and in the past they have been done separately. And for the first time with this community health improvement plan, we are doing them together. We know that we are serving the same group of people, and why duplicate resources? And so we are really working together on this effort and implementing it for the county as a whole. And the goal is really creating that long-term systematic effort to drive public health outcomes. It's based on the community health needs assessment that was done. We presented that a couple years ago, and it's really the goal is to help define that vision for the community through that collective process. We use a mobilizing for action through planning and partnerships process. And the collaborators, again, as was mentioned, the local government, DHHS, Healthy Montgomery, many entities from across county government, health systems, and health action priority teams. And our health action priority teams are starting work now to review the goals, strategies, and objectives that Kimberly is going to review in just a moment, and translating those from objectives and strategies into action.
And so these priorities really represent an important evolution of how we work together, like Dr. Davis mentioned. So although we do have separate CHNAs, one from the county and one from the hospital systems, we really wanted to come together and translate those needs into action. And we didn't want to wait for that action to start. So instead of waiting for the next cycle where we could have a joint CHNA and a joint CHIP, we really wanted to start the conversation now, action now. Instead of moving forward with separate plans, we created this shared roadmap for improving community health. And as a result, this is what you see here, a unified set of priorities that really guide the work across the county. Next slide. So starting with access to care, what's important here is not just the list of services, but what it represents. So this priority really reflects a shared recognition that access is still uneven across our county, particularly in behavioral health, specialty care, and culturally responsive services. What's different now is that this isn't owned by any one system. Hospitals, public health, and community providers are all approaching this from different angles, but with a shared expectation that we are collectively closing the gaps together, not addressing them in isolation. So this becomes less about organizational ability and more about a shared system responsibility. Next slide. The second priority is where you really see the shift go upstream. This is less about treating conditions and more about creating the conditions that allow people to stay healthy in the first place. So what stands out here is just really how much cross-sector alignment is needed to make this successful. So healthcare, public health, schools, community organizations, we're all contributing efforts in different ways. And so the value of the joint CHIP is intentionally aligned so that they reinforce each other rather than compete or duplicate efforts. So this is really about moving toward a more coordinated approach to prevention and well-being. Next slide. And the third priority really expands this lens even further. This is where knowledge that, health is shaped outside of the healthcare system, not within it. There's definitely more impact on how we live, work, and play than what can be provided from the clinical side. So housing, food access, transportation, system navigation, these are really not traditional healthcare issues, but they're absolutely about health. So this priority really asks us to work differently, kind of bring in partners beyond healthcare and aligning efforts across sectors. So less about, the programs that we can implement, but more about how we collectively address the conditions that our residents live in and that really drive and impact health outcomes. So across all three priorities, what stands out is that it's about how we're approaching that work. So really reflecting a shift from independent, even the hospitals didn't have joint, needs assessments and implement plans prior to this. And so really looking at how we can do that independent effort more aligned and really approach the hospitals in the county and the community partners as one. Moving from a joint CHIP was really a major step, and we only look forward to expanding that work as we then join to have a joint community health needs assessment and a joint CHIP in the next cycle. Next slide.
Thank you. And in terms of next steps, so the CHIP has been approved by all entities. The health priority action teams have been identified and they are starting to work. The next thing that will come out is a shared dashboard for monitoring and evaluation. So we'll be able to track that. Hopefully in October, we'll be able to share where the progress is on some of these entities. So thank you for that. We will shift gears a little bit to talk about Medicaid and Medicaid updates. So we came to you earlier this year, I believe in February, to talk about some of the changes that are coming as a result of HR 1. And go to the next slide. And we shared this timeline. We are here now in June with the release of the interim final rule on work requirements. They also recently released the interim rule on frailty. The things that are coming, just a reminder of the big changes that come with HR 1, changes to work requirements. So now people are required to show 80 hours of work per month, or they are at risk of losing their Medicaid benefits. They also need to reapply for their Medicaid benefits every 6 months. So in the past, you had eligibility, it was eligible for a year. When we think about our own health insurance, usually we have it for a year and then there's an open enrollment period and you have to reapply. Now, folks with Medicaid will then have to prove that they qualify every 6 months. Those changes will take effect as of January 1st of 2027. What is looming much more closely is the October 1st deadline where asylees and refugees will no longer be eligible for Medicaid. So pregnant women and children who are asylees and refugees will remain, but otherwise they will lose their coverage. That comes into effect on October 1st. Can go to the next slide. When we look at the state of the uninsured in Montgomery County, there are some good news and bad news. So the good news is that the county average is 6.9%, which is an improvement from 2022 when it was 7.4%. However, we still remain above the state average of 6.3%. And when we break that number down a little bit more, we see that the highest percentage, that the highest representation of that 6.9% is in Hispanic residents, with 18.8% being uninsured. The safety net, Montgomery County has created a unique safety net across the state of the Montgomery Cares and Care for Kids program. Montgomery Cares and Care for Kids care for about 34,000 of the uninsured population, which represents about 45% of the uninsured population, but still leaves an estimated gap of about 40,000 residents without coverage. And this number is expected to increase as a result of HR 1. Some of the things that we are doing to prepare, we have an ongoing task force on Medicaid, which includes representatives from DHHS, healthcare organizations, community health advocates, nonprofits, PCCs, a great partner in this. We are planning for a Medicaid symposium, which will happen in August of 2026 to help educate community nonprofits about these upcoming changes so that they can then educate their community about them. The state has already released a toolkit for educating the community, and our OESS team is now involved in intensive training with the state to be able to train the trainer. We will then spread that knowledge in August, but it will be really important to make sure that all bits of the community that are affected know about these changes and how to stay connected. The state has done a lot of work in trying to make it as easy as possible for people to stay connected. They are working with labor to, if anybody has a job, that those records are transmitted so that they can be automatically re-verified. They are working on the definition of medical frailty, because there is a little bit of leeway in there, so that if somebody say has diabetes or cancer or substance use or things that can be designated as medical frailty, so that they do not have to do those redeterminations. So the state is working hard on that. What we have not seen investments in are investments in the people to help the people. So the state is focusing their efforts on the technology and the integrations of systems to make that easier, but they have not, and we as a county have not invested in the people that are going to be needing to do more of that work, right? Those redeterminations that were happening once a year now has to happen every 6 months. You're essentially doubling people's caseloads, as well as making those caseloads heavier, because now they have to look at work requirements, which is something that they didn't have to do before. As I mentioned earlier, asylees and refugees will lose their Medicaid coverage on October 1st. And we talk about Montgomery Cares being that safety net for folks. The budget for Montgomery Cares covers 78,000 visits, which as it currently stands, current enrollment is about 2.4 visits per person. As we think about how or if Montgomery Cares could absorb some of those folks, there are hard decisions that the county will have to make around budget, around prioritization, around wait lists, around access, to try and absorb these folks, or how we think about how we continue to care for this community. We know what we learned from COVID is that when we have pockets of people who are uncovered and are sick, it benefits no one in the community. And so it is really important for us to make sure that we are thinking about how we are integrating these folks into the community and into the healthcare community. As we saw in an earlier slide, when we look at chronic disease, as those rates are on the rise, when we, again, think about this population, if they are delaying care, delaying preventive care, delaying primary care, then they are showing up in the emergency room, which is the most expensive, least effective place to get care, especially when you're talking about chronic disease. So we will be coming to you all again to talk about this. And when we get to the Q&A portion, I would actually really love to hear from the Board of Health on your thoughts on prioritization as we think about this population. With that, I will turn it to my behavioral health colleagues.
Good morning, Ben Stevenson II, Manager 3 for Prevention and Harm Reduction Services. So it's a pleasure to be with you this morning. Council President Fanny Gonzalez, I want to send my empathy to those impacted. I'm going to share data on behavioral health, giving a substance use update as far as overdoses in the county, programs and services that we're implementing, and other things that are coming up the pike. Oh, no. Oh, okay. Sorry. All right. Just want to make sure you can hear me. All right. Okay. Next slide. All right. So as far as our overdoses, as far as trends are concerned, currently we have 30 fatal overdose intoxications recorded in the county. That is actually a 3% decrease from the same time period for 2025. With that decrease, we still see burdens of disproportionately impacted male population, which accounts for about 72% of our overdoses. We've also noticed that fentanyl is involved in 17 out of those 30 cases. And we know that, with that 22% increase in fatal overdoses involving opioids as well. So we've also been mindful that as far as our overdoses, they haven't necessarily been exclusively to opioids. There's been a lot of polysubstance use in terms of our overdoses. So we're also monitoring other substances, which includes alcohol, stimulants, including cocaine and other substances and other adulterants that might be in the substances as well. Next slide. Sorry, I had my slide deck messed up. All right. So for this slide here, this data reflects unintentional drug and alcohol intoxication deaths in Montgomery County. So this source came from the Maryland Vital Statistics Administration and the Office of the Chief Medical Examiner's Office. So this count is for 2022 through 2024, and these are preliminary numbers. So they're subject to change as far as investigations are finalized. This also looks set in accordance with like the National Center for Health Statistics. When counts are lower than 10, they'll extract that data just to try to sustain privacy of those individuals. When you look at broader trends, so like our opioid-related deaths have impacted all ages, age groups over this period of time. The major group that has been impacted the most has been the 25 to 34 age group, which is that yellow line that you see on the slide. 35 to 44 age group, which is the black line, historically experienced higher numbers of annual fatalities, which kind of peaked in 2020 to 2021. But following that period of high totals, the number of annuals across all age groups have trended down from 2023 to 2025. So we're actually moving in the right direction, even though we're seeing some of the groups still proportionally impacted. Next slide. So one highlight I wanted to share is that we have deployed Narcan kiosks within the county. We currently have 4 in circulation. This is actually in preparation for the deployment of harm reduction vending machines, which will also house Narcan and other supplies to support individuals struggling with substance use disorder or just struggling with other, health and wellness challenges. So with these kiosks, we've dispensed about 816 boxes of Narcan. That has been for the second and third quarters of the year. We anticipate peaking over at least 1,000 for the final fourth quarter of the year. But we're moving in the right direction as far as making sure that Narcan access is available. And then we're also working with a lot of groups within the county as far as deployment of those vending machines within the county as well. Next slide. All right, for our overdose prevention team, we've been working diligently trying to get a strategic plan in place moving forward to kind of guide our work for the next 3 to 5 years. So we've broken it down into 3 different pillars. So you can see prevention and harm reduction, treatment and recovery, and then public safety and systems interdiction. So our prevention and recovery will focus in on expanding evidence-based prevention initiatives and strategies within the county, focusing on like direct service programs like 5 and Life Skills or other programs that might be in upper elementary, lower middle school programs as well. We're also looking to increase youth engagement, so partnering with like the Youth Resiliency Initiative and things like that, trying to give more young people positive opportunities to belong to something that's bigger than themselves. For harm reduction, we're still focusing in on Narcan saturation, so trying to make sure we reach a annual number of about 1,000 residents on an annual basis, and then also prioritizing those high-risk zip codes in regards of overdoses, high Narcan administrations, and things like that. We're also wanting to do work around stigma reduction, trying to educate the community around substance use and mental wellness. And then for the treatment and recovery, they had a conversation around specialty housing, supporting housing for transitional age youth, persons in recovery as well. In addition to that, expanding clinical care like MAT programs, but then also increasing like the warm handoff from like incarceration to community-based MAT programs. And for public safety, we talked about our drug take back initiative. So law enforcement wants to increase frequency and visibility of drug take back initiatives, removing those unused medications from your homes and things like that. And then also just kind of maintaining localized access in the 24-hour access to those. And also they looked at increasing like the guarantee that looking to try to have like 75% of MAT programs from incarceration receive that are exiting custody receiving that re-entry services directly to substance use treatment programs, recovery housing, and other supports, hoping to reduce relapse and prevention efforts and things like that. Next slide. That's it. All right. Thank you for your time.
Thank you, Ben, for all the work that you're leading and supporting. Ben has done an amazing job with the overdose prevention team and so many efforts in the community. Council President Fanny Gonzalez, my heart has been with Caracas since I learned about the earthquakes, and it remains there. I'm going to go into an update on suicide and intimate partner violence. Next slide, please. Okay, this is a suicide mortality rate trends information. You've got a graph line there to look at. Our CDC 2025 provisional data that's on here, that little asterisk on the 2025 year, is as of June 19th. And while it will be finalized after today, we don't tend to see much more information come in after June that impacts the trend line. So you'll see here that Montgomery County experienced an increased suicide mortality rate of 9.9 per 100,000 residents in 2025, and this remains below the national average of 13.3, but it is higher this year than the Maryland rate of 9.6. Next slide. This gives you a sense of context in terms of the actual count. So we're talking about in 2025, so far in the provisional data, 638 suicide mortalities reported across the state of Maryland and 107 in Montgomery County. So that represents about 16.8% of the total suicides in Maryland, and the Montgomery County population does account for about 17% of the state population, but of course it is an increase of 11 suicides compared to 2024. Next slide. And I think this is the most important slide in terms of interpreting that data that I just shared. This is a trend graph of suicide mortality rates for Montgomery County versus Maryland by race and ethnicity. And where you do not see a bar, those blanks again represent rates that are low enough that they needed to be suppressed, as Ben shared earlier, in order to protect individual privacy. But in Montgomery County, the two demographic groups that experience increasing rates overall from 2018 through 2025 are non-Hispanic African Americans and Hispanics, whereas for the state of Maryland, only non-Hispanic African Americans showed continued increase over that long range. If we look at the immediate past year, from 2024 to 2025, though, the only demographic group that experienced an increase in suicide mortality rate in the county was our Hispanic residents, which jumped up significantly from rates low enough to be suppressed since 2021 to a rate of 8.9 in 2025. The state of Maryland also saw a less striking but still significant increase in suicide mortality rates for the Hispanic population. And so while, rates are always better indicators than counts for assessing trends, since those suicide mortality rates for Hispanics in Montgomery County were low enough to be suppressed from 2021 to 2024, what we can share about the counts is that the actual number of suicides, not the rate, more than doubled for the Hispanic population from 2024 to 2025 to a total of 21 individuals passing by suicide. And with the majority of those being completed by Hispanic males ages 25 to 64. And that 25 to 64 age range, the general adult age range, is the most, it is the same age demographic that is persistent across race and ethnicity in terms of the majority of suicides that we see completed. But this is significant because that increase in count of at least 11, it's not an exact number, more than doubling, Hispanic individuals dying by suicide can account for the entire increase in the counts that you saw on the previous slide from 96 to 107 individuals from 2024 to 2025. So it really underscores potentially the impact of economic and housing stress among working age Hispanic men, immigration-related stress, of course, the inability or stigma related to seeking services and social isolation and weakening community protective factors for Latino men in our county. Of additional importance, of course, though, is that the mortality rate here for our non-Hispanic African Americans in 2025, it didn't increase, but it had increased in 2024 from years prior to a rate of 10.5, and that surpasses the Maryland rate. And it didn't decline in 2025. So that speaks to persistent structural inequities sustaining elevated risk among African Americans. The rates for our Asian and non-Hispanic white Montgomery County residents decreased from 2024 to 2025, but non-Hispanic white residents consistently continue to experience the highest suicide rates overall. Next slide. We're going to look very quickly at some ER visit-related trends, and this is in regards specifically to suicide attempts. This has calendar year 2026 data, so more recent data that's currently in progress. And what we're seeing mostly is, consistent trends in total ER visits and visits by race or ethnicity over the years, but a linear increase in ER visits due to suicide attempts among Hispanics from 2022 to 2025. That was a 33% increase. Next slide. Looking specifically at our younger population, those ages 10 to 21. Among those youth, ER visits due to suicide attempts among Hispanics increased 56% from 2020 to 2025, with visits from non-Hispanic white youth increasing 22% and non-Hispanic Black youth increasing 13% during the same 6-year span. Next slide. What we really cannot wait to get off the ground, of course, in relation to being able to dive in more deeply around causal factors and anything and everything we can do to prevent any of these suicide fatalities, is that Maryland's 2026 Local Suicide Fatality Review Teams Act, House Bill 1012, was authorized. It's going to be effective in October of this year, and it allows us to create multidisciplinary, multi-agency fatality review teams to help prevent future suicides. So similar to our overdose fatality review team and our child fatality review team, we will finally be able to, of course, in a post-mortem situation, look at the details that led to potentially someone completing suicide and look at our systems and structure and be able to better identify what we can do to support our community. Next slide. Here's our update on intimate partner violence. As of June 18th of 2026, the 2025 census population data had not yet been released. So the 2025 figure that you see on the chart on the left there for the age-adjusted rate of ER visits, it is based on an estimate of population change from 2024 to 2025. So that should have an asterisk on it too. But it does reflect that in terms of the information we have now, that the intimate partner violence ER visits in the county, while they increased from 2019 to 23, they decreased since from 24 to 25, and that represents the first time that Montgomery County rates have been lower than Maryland rates since 2019. I have to say, though, that from the experience of our trauma services program, we think this data needs to be interpreted very cautiously. It does not necessarily indicate a reduction of intimate partner violence incidences. ER visits represent only the visible portion of intimate partner violence, right? It captures only survivors who experience injuries severe enough to seek medical care. And then we also know we have a portion of our community who's is less likely to seek that medical care even in those moments at this time. Many survivors historically never seek emergency medical treatment due to fear, coercive control, financial independence, all the factors that are dynamics in intimate partner violence situations. So this ER data should be viewed as a minimum estimate rather than a true prevalence of intimate partner violence. Our trauma services unit did not experience a decline in intimate partner violence related activity, serving 39 more domestic violence survivors in fiscal year 25 than 24, for a total of over 1,700 survivors that received our care. And I think we're moving on to general updates.
I will test the waters here because we've been going for 45 minutes. We have general updates on lots of things: PFAS, the Potomac Interceptor, the Germantown emergency room closure, the mobile health van. Keep going here. All right, we'll keep going. I mean, I've never seen you guys not want to go. We got lots of water to talk about. So, all right, we'll turn to Mr. Sean O'Donnell.
Thank you, Dr. Davis. If we can go to the next slide, please. And the next one. So we have given the council some updates previously, but we just want to let you know where we are. The PFAS contamination was found in a small stream near the Great Seneca Highway. These were elevated levels of per and polyfluoroalkyl substances, commonly referred to as forever chemicals. There are hundreds of different types of PFAS, so we just collectively use this acronym. to describe it. The first thing we want to emphasize is where this was found is not intakes for the drinking water. The drinking water is monitored. There are federal regulations going in requiring this monitoring. However, our partners in DC Water and WSSC have been monitoring this for years. Actually, this monitoring is what helped to alert. They do some preliminary testing at downstream, upstream, just to see what's going on with the water. They saw some slight elevations, and as they detected things, Maryland Department of Environment stepped in, did more extensive testing, and found these much more elevated levels in these locations. The locations happen to be on and adjacent to the site of the former Public Safety Training Academy. It's suspected that the firefighting foam, which used to have PFAS intentionally added to it, contributed to this. We no longer use that foam. We no longer use foam with PFAS added to it. The county and state currently have lawsuits against the manufacturers of it because they believe they knowingly put them in despite knowing the health risks. Looking at this, the reason we're concerned about PFAS is research has shown that long-term exposure to certain PFAS compounds will have potential health risks. At this time, there's no federal standards for PFAS in groundwater or surface water. It's just for drinking water. So we do look at that drinking water standard when we try to consider what the risks may be. We don't expect that people should be ingesting water from stormwater ponds. We are concerned about any leaching of water potentially into private wells. Our partners in DEP are reaching out to determine which wells may still be active. I believe they've identified less than 10 wells in the area, and they'll be providing free testing within a mile to determine if there's any impact to that. During this time, a number of response activities have occurred in the affected area. DEP has gone and done door knocking, handed out flyers to let people know of the concern. An email distribution list was set up that our residents can sign up for to receive updates. We held an in-person town hall on June 17th, and a follow-up virtual town hall will be held tomorrow evening. Additional water and soil testing are planned in the area, and we are participating in a joint task force with DEP, MDE, WSSC, and our county parks. Sorry for all the acronyms, but just trying to speed this along. So we also issued a public health advisory, and that advisory is essentially, out of an abundance of caution, asking people to avoid contact with the water. We don't believe there's a high risk with skin contact of the water. The testing has shown that these PFAS are rather large chemicals for what they are unlikely to be absorbed through the skin. We are concerned about ingestion. So we don't want anybody accidentally drinking the water. We don't want the pets or their children accidentally drinking the water. We don't want people to consume fish that they may catch in that water. So DEP has put up orange fencing around it, lots of signage. So we really do think we're keeping people out of that, and we're just hoping to gather more information and reduce the exposure possibilities. Next slide, please. So going back to the Potomac Interceptor sewage overflow, again, I think you have a great deal of background in this, so we won't go into too much detail. But following the release of an estimated 243 million gallons of untreated wastewater from a breakage in the Potomac Interceptor pipe, this water flowed over the land and into the Potomac River on January 19th. Water testing and remediation began not too long afterwards, and by March 14th, the pipe was repaired and restored to the normal operations. Maryland Department of Environment has been actively filling their role with the oversight of the remediation and making sure things go back to where they are, ensuring that testing is occurring. Drinking water has never been affected by this again, which is a good thing. So again, for this issue, we issued a health advisory initially for the water as the water levels were very high in bacteria. And as the water levels came down into pre-leak conditions, we lifted the water advisory, but we retained a sediment advisory because we didn't have testing at that time for the sediment. We now have had 2, and in some cases 3 sediment samples taken along the areas of concern. Initially, they showed some very high levels of what may or may not be active bacteria. It's DNA testing, so we don't know how viable that is. There are not existing standards of what we should expect to see in sediment the way there is for water. There's not a recreational standard for sediment. We've seen some of those levels come down and some bounce up a little bit. Their MDE should be collecting another set of specimens this week, I think potentially yesterday. And so within a week's time, we'll have some more data and revisit that. We are hopeful that the continued warmth, while not ideal for other health conditions, is hopefully knocking back those bacteria levels. And when we see some progress, we'll be lifting the sediment advisory. So the next slide, please. And this is just showing the area where the red stripes on the map are the areas where the sediment advisory is still in effect. Some of those areas have shown some good results so far, but again, we're hoping within the next week or so we'll have additional data. Otherwise, we've been in contact with the community, with the recreational community. They understand what our concerns are and they're taking appropriate precautions. Next slide.
So just an update on the Germantown Emergency Room closure, which is happening today. So today is the last day for the Germantown Emergency Room. It is set to close, and the new Adventist tower at Adventist Shady Grove should open tomorrow. They notified the public about this several months ago. What is happening here that is unique is that there is savings that are coming back to the hospital because it's less expensive to operate one emergency room rather than 2. And as part of that, $2 million of that is coming back to the community. And the HSCRC has asked the county health department to work with Adventist on a plan for those $2 million. And we are using that to address the community health needs of the Germantown area, identifying that that is the region where folks are now without care. And we are specifically targeting the Montgomery Cares population. When you look at the numbers, there was about 12% of the population that was seen at the Germantown Emergency Room that is uninsured. Remember that uninsured rate that we saw earlier for the county is 6.9%, so they were seeing a disproportionate percentage of uninsured residents. We imagine many of them are Montgomery Cares residents. And so there's 4 pillars of the plan. One is to expand primary care access in Germantown, so that's to help support our Montgomery Cares clinics with additional support, after hours care, same day triage, same day care for folks who have urgent care needs. To provide an after hours nurse triage line to help triage folks to the most appropriate place of care. So this will be from 4 p.m. to 9 a.m. during the week and as well as on weekends to have a nurse, so the Montgomery Cares client will call in to the triage line and they'll say, you know what, that's appropriate, you should go to the emergency room. Actually, that would be best served at urgent care. Here's the urgent care that you should go to, and we'll help cover that visit. Or, you know what, that's great, but we can get you in for a primary care visit with your PCP tomorrow. So we're really excited about, when you look at the bigger problem of emergency room wait times, a lot of that is because people can't get to primary care. They don't know the right place to go to, and so this should also help to alleviate some of the overburden in our emergency rooms. The third is enhanced access to urgent care. So one of the things that Montgomery Cares does not currently provide is coverage for urgent care visits or emergency room visits. And so this will then open up urgent care visits for our Montgomery Cares clients. And lastly, we are working on 911 innovations. So we are working with Chief Kaufman and the EMS team to help support the Mobile Integrated Health Network and other things to help people get to the most appropriate place of care. And oftentimes that is not an emergency room. If it is an emergency room, we want the emergency room to be ready and not clogged with people who would be better served in other places. So of this $2 million investment, 87% of those costs go to direct patient care. We are also excited that we'll be working with PCC for part of the administration of that. They have been a great partner in this process. The most important thing is how we're going to measure success for this. Of course, we're going to be tracking the number of visits and calls and who's accessing the triage. But really, the thing that is most important is how we are getting those connections. So are people being connected up to primary care? Are we decreasing the burden on emergency rooms? Does this impact emergency room wait times and the overall impact on population health? Again, as this all kind of comes back to our emphasis on chronic disease and how are we making sure that we're addressing chronic disease in the community, and this is just one more tool in the toolbox. It is rare that $2 million comes to the county to invest in this way that doesn't come out of the county budget, as we've just come through a complicated budget season. And so we really appreciate this investment, and again, another opportunity to work with our hospital partners for the needs of the community. With that, I will give a little bit of a highlight here for the State of Black Health Survey that is in the community now. There are two parts. It is a community survey. There's the QR code there. We encourage you to share it around. We are hoping to get to a large number of people to complete the survey and working with community partners to do so. But there will also be a series of listening session focus groups with specific communities, both the healthcare community, the faith community, making sure that we get to our historically Black communities in the county. We will gather and analyze that information to develop a roadmap to better serve the needs of the county's Black residents. We are looking towards this survey and to help develop those potential opportunities to improve the health of African Americans, continental African, Caribbean, and Afro-Latina residents of Montgomery County. And that data will help produce actionable measures focusing on prevention and chronic disease, and really demonstrate how Montgomery County compares to the state and surrounding counties. It has been a number of years since we have done this in the Black community. The Latino Health Initiative and the Asian American Health Initiative have both done surveys in the last 5 years, and the African American Health Program has not. And so we are excited to launch this program. And we hope that this will then also inform our budget priorities for the FY28 budget process. And before I toss it to Sean for our infectious disease updates, I do want to make sure that we highlight the heat that is coming this week and just say a few words about that. Dr. Bridgers couldn't be here this morning because he's in the senior emergency management planning call for this. I want to make sure that we are cautioning people about the heat. There's kind of the trifecta of this being a holiday on top of the heat, and so many of the cooling centers, libraries that typically would have been open for people to go are closed. I want to applaud the rec department and libraries. There are 5 rec centers that are going to be open. There are 3 libraries that are going to remain open through the holiday weekend to be available for people for the heat. I believe the regional service centers are also going to remain open. But we just ask people to maintain caution, try not to be out in the heat of the day. And I want to remind folks that alcohol is a diuretic. It will dehydrate you. So if that is the beverage you're reaching for when you are thirsty, it will just make you thirstier. And so putting that caution out there for people to be mindful through the holiday weekend. And with that, I will turn to Mr. O'Donnell.
Can you go to the next slide, please? So the first thing we'd like to discuss here is within arboviral illnesses, which can include illnesses passed by mosquitoes or ticks. In this case, we've seen an increase of tick activity in Maryland and much of the eastern United States. That we are seeing increased tick bites happening at our emergency rooms. And as you can see, we have 2 charts at the bottom showing over the course of years. On the left, the increase in tick-borne disease cases in Maryland. On the right, another one going in the opposite direction of years. From in 2022, we had just over 2,000 tick-borne diseases in Maryland. The previous year, it was half of that. In 2023, it went up some. And in 2024, it was over 3,000. So we don't have the full data for 2025 yet, but these are going up quite a bit. The most common one is Lyme disease, and that predominantly happens from the black-legged tick, otherwise known as deer ticks. They're pretty common. We give you an idea of the size of them. They tend to bite when they're in the nymph stage or the adult stage, and the nymph stage is very, very small. The adult stage, you can actually see them a little bit better. So we are warning people that if they're going to be out in nature areas to wear long, loose clothing. You can wear insect repellent on the outside of your clothing or exposed skin to help prevent tick bites as well. There are some other tick-borne diseases that are being transmitted, but nowhere near, as you can see from the right table, nowhere near at the volume as Lyme disease. But this is, again, we're just trying to raise awareness that this is happening quite a bit more. I don't know if we're yet at the peak of the tick season, but it's certainly still going on. So we wanted to raise that awareness. Can we go to the next slide, please? These are some of the symptoms that people can look for with Lyme disease. And often a lot of the symptoms are similar to other types of illnesses, whether it's fatigue, muscle pain, headaches, chills. But also with Lyme disease, we typically see a rash that can look like a bullseye, and that may indicate that that's happened. It often doesn't happen for up to 30 days afterwards, but it may be a week, 2 weeks. So in addition to avoidance and using insect repellent, we also suggest people check themselves for ticks when they come inside. Washing or running your clothes in the dryer on high heat will kill ticks as well. After you come in, they may be residing in your clothing after you come in, so that's another thing to do if you've been out in the wilderness or in areas with tall grass. Next slide. So now we're just a brief update on the Ebola Bundibugyo virus outbreak. As most folks know, this is an ongoing outbreak that's occurring in Africa, specifically within the DRC, Uganda, it's been over the past month. All returning U.S. citizens who have traveled to these affected areas are being tracked by CDC and by the states. We are being alerted by Maryland Department of Health of any residents who come back to our area who's traveled to the area. We are doing what we call self-monitoring. We're in contact with these individuals, and we've been tracking them. I think there's been just over 90 individuals who've come back from this area to Montgomery County. Most are marked. Almost all are marked as low threats because they have not really had contact with ill people, but their risk concern is the travel to the area. So we're continuing to monitor and make sure that there are no cases. We've had no cases since this outbreak. So we just wanted to give that update. Unfortunately, we do expect that the outbreak in the affected areas will continue to get much larger. And there'll be a lot of active efforts to try to control that. But the risk locally is very, very low. Can we go to the next slide? And now I will turn it over to Dr. Rogers.
Yes, good morning. The mobile health clinic has been traveling around Montgomery County with the vehicle for the past year. Prior to that, we were doing some pop-up events in local organizations, just basically medical, dental, and behavioral health screenings. But we've been traveling around Montgomery County providing integrated medical, dental, and behavioral health services for the past year. I can say that the community prefers, many residents prefer to receive services in the places where they live, where they play, where they worship, where they receive food from our local food pantries. And so there is more demand for our services than there are resources. Unfortunately, there are times where we have to redirect individuals to other resources, brick and mortar resources, to receive services because we just don't have the capacity to see individuals within the community. And so this has been a great resource for the Montgomery County residents. Next slide, please. Overwhelmingly, we have seen a significant percentage of our Hispanic and Latino community. As we go into the next fiscal year, one of our goals is to broaden our reach to the African American Black community by targeting more of our residents within the East County community. And so we are excited about some of the partnerships that we have as we come up in FY27 to better engage those communities as well, in addition to some partnerships that we have with other departments throughout the county, such as the libraries and parks, as we offer pop-up clinics in various targeted zip codes so that we can better engage residents across different demographics. Next slide, please. So I think the point I will mention on here is kind of where I started at. The demand for services outpace our capacity. And so every time we go out into the community, we have a full schedule based on our capacity. I think for dental, we've been able to see probably about, on average, maybe about 8 or so patients every time we go out. For mental health, it's typically around 6 or 7. And then for medical, it can range anywhere from, just depends, anywhere from 8 to probably like 16, just depending on the types of services that the patients would offer. And so what you see reflected in this data is just max capacity. And also will note that 30% of our clients receive more than one service per visit. And so we really pride ourselves on integrated approach. And so a patient will come in for dental at 10 a.m. and then they'll see a nurse practitioner at 11 a.m. And then some patients will also see a behavioral health professional at 11:30 a.m. as well. So we're able to really meet all of their needs right there in the community. And then we also want to make sure that we link and refer patients to health homes so they can have a primary care provider, so they have a dental home, a behavioral health home, as well as to address their social needs is something we also do. So that's a little bit about the mobile health clinic over the past 1 year. Next slide, please.
Actually, I think we're going to pause here and jump to the end, just to the final slide. We had a few updates on the Maryland vaccine program and smoking, but we can send that to you after because I want to make sure that there's time for questions. I do want to highlight, there's 5 of us who are sitting up here, but there's a whole bunch of other folks who have been really helpful in the presentation. Certainly Dr. Bridgers, who couldn't be here, Dr. Ashford, who also, due to health issues, couldn't be here, but I want to highlight our chief epidemiologist, Dr. Chun-Fu Liu, Elizabeth Beck, who staffs our Healthy Montgomery, Dr. Richard Nemhard, who is our chief data strategist, Kelly Velasquez-Umania, Young Yu, many other folks, Dornay Hill, Sarah Rose, such a big team of folks that make the magic happen at HHS and Public Health. So I want to make sure that we are highlighting that. And as we turn it to you, as you guys, again, are firing questions at us, I would also like to turn some questions back to you. I mentioned earlier around prioritization around this community that is losing insurance, and how we think about kind of reallocating public health resources and personnel back towards chronic disease prevention and management, and really thinking about that, those 4,000 people who are sitting in that insurance coverage gap. So thank you for allowing us to share these updates.
Thank you so much for all your work. I thank you guys, the HHS team. You guys are really, every time I see you, you really show that it's not just work, you really care about the community, and it shows every time you come here and present. So I want to thank you for all that. For the state of the Black health, when is your deadline? When are you going to have the report done?
So we are currently still in the information gathering phase. So the survey will be open through July, and then we'll start doing focus groups through the summer, early fall. And so hopefully the data by the end of the year.
I'm asking, and my colleagues don't know this, but in the Economic Development Committee, we're going to have a session in July about the state of the Black worker. And the reason why I decided to put this together is because of all the policies that are happening at the federal level and how it has impacted, especially the Black community. So we are drafting the agenda as we speak, and it's just, what a coincidence. So maybe I want to run some of the things that I'm working on with you, because I'm sure there are going to be some connections there. At the very least, you should watch the session. It's going to be mid-July, so stay tuned for that one. I'm going to open it up with colleagues. I'm going to start with Councilmember Shabra Evans.
Sure. Great presentation today. Very good information. And I really do appreciate the leadership of Dr. Davis and everyone at the table. So I think the question I was going to ask you, Dr. Davis, I think you just answered it. I was going to ask you, I know that we know the percentage of people that are uninsured. Did you just say that there are 4,000 people that are possibly going to lose their Medicaid insurance? Because that's right.
So we don't have a hard number on that. And there's the asylee refugee population that's probably in the 2,000 to 3,000 range. That's a really rough estimate. Still trying to get kind of that hard number from the state.
Okay.
So I want to just kind of put it in context a little bit. Those folks will not have access to insurance anymore, other than, they cannot buy it on the exchange, they cannot get it through Medicaid. And it is a little bit different from the population who will get caught up in administrative delays come January 1st. So the folks who lose Medicaid because they didn't comply with the work requirement, or they didn't get their paperwork in because it went to the wrong address, are in most cases still eligible for Medicaid. There's a paperwork administrative thing that has to be fixed, but they can get back on. These folks who are losing it in October do not have access another way.
Yes, so my question was going to be, do we have a way to identify the people that are going to lose it in October? And the other question is, are we prepared, or what can we do, excuse me, to help our hospitals? Because I'm making the assumption that the people that no longer have insurance, they're going to go to the ER, they're going to go to the places that you're talking about that you don't want people to come. And so then I'm going to ask you another question. So we can't do it by zip codes. It seems like some of the information that you've been providing, where you're trying to put different, where you're trying to put an emphasis and a focus on having, you talked about we're closing in Germantown, but we're going to open up something in Shady Grove. I didn't know if we can correlate to the areas where people are going to lose their insurance, that we'll have places that they can go to where they can be able to provide, where they can get that additional support. So I don't know if you can answer any of those questions, but that's what I was thinking about when I heard you talking earlier.
So part of the challenge, and one of the reasons that the Maryland Department of Health is hesitant to release that information, is because that is inherently tied to immigration status.
I can't hear you. I'm sorry. Can you speak?
It is because that's inherently tied to immigration status. And so there's concern about having a list of folks who have questionable immigration status and targeting them. I think the best way to really be able to support them is to prop up our Montgomery Cares clinics. Many of these people are probably already, who have Medicaid, are likely already being seen at our Montgomery Cares clinics with Medicaid, and their status will switch over. And so as we continue to try and find ways to support that safety net, it's going to be really important that we are supporting Montgomery Cares and their ability to see more patients. That patient that they were seeing under Medicaid that was paying about $150 to $200 a visit, if they were to switch to Medicaid, to Montgomery Cares, is now getting seen for $130 a visit. That clinic we know is going to also have financial issues. And so, that's where we are really trying to focus our emphasis in beefing up that safety net to help these folks.
Okay, very good. Now, are we somehow connecting with our faith-based organizations? I could say, for example, Kingdom Fellowship AME has a Kingdom Cares, which has a health and wellness component. So that's another avenue where we can work with our partners to share what's coming up. That way we can better help support our communities or the residents that at some point are not going to have this coverage. And then, so that's...
Absolutely, and this community forum that's happening in August will be a very big target to get the folks so that they can get the message out to their communities.
Okay, and then I wanted to go to behavioral health. Can I make the assumption that where the Narcan kiosks are located is where we've been heavily hit with some of the doses or high doses or incidents?
Yeah, so we did identify locations based on data.
Okay, that's what I thought.
But then also, we've had some requests for hosting Narcan
Okay.
kiosk as well.
Okay,
And
very
then
good.
when we deploy the vending machines, we'll also look at data specifically at that.
Okay, I assumed that, but I just wanted to ask that question and get the actual information. Then my last comment, it's not a question, is that I observed that when we were in the area of suicide and intimate partner violence, that the area where I live in, 20906, that was the high number of suicides, the youth. The range from 10 to I forget what the end age was, and then that was the high number of hospital visits for people attempting suicides. Are we using that data to correlate to all the other things you all talked about, affordable housing, transportation, and everything else? I'm making the assumption that all these different things that you talk about today will impact those communities. And if we know, particularly we have that data, like how are we getting in there and helping and working with the school system?
Yeah, absolutely. Those are zip codes of the residences of the patients that are arriving at the emergency rooms. We are in regular communication with MCPS about this data, and so absolutely. Aside from looking at the racial and demographic breakouts, we're also looking at the geographic. We have so many more slides we could have shared. So we do have some heat maps
Sure.
related to that we're looking at as a work group.
Okay. I just pointed that out. That hit me hard because that's where I live. And so I was not aware that it was really prevalent in that zip code. So this was really good information that you shared. I appreciate all the work that you all continue to do, and just thank you. And I'll be looking out for that August town hall and the survey and passing it along through the different organizations that I'm affiliated with. That completes my questions. Thank you.
Great questions by Councilmember Evans, and just to point out that another relationship there in the data, we have done quite a lot of work on the issue with drunk driving among Latinos. And when I say Latinos, I mean men, Latino men, and it matches the number of suicide. And based on the conversations that I have had with this community, people are so depressed. They feel lonely. The immigration crackdown that we are facing is a big driver for this, among everything else. So the pain is real. Next, we have Councilmember Don Lukey.
Thank you, Madam President. And yeah, it's substantial and horrific. And I'm grateful for the deep bench that you have, Dr. Davis, and the team assembled up here, because, you know, there are many behind each of you in each of your areas who support this work. And we are blessed to have them, because we're going to need every single person, all hands on deck. I had a question about the self-harm related data. Does the attempts data include only those instances where there was a subsequent ER or transport to definitive care at an acute medical center where there was self-harm of some kind, or does it also include where self-harm was threatened, an intervention happened, and there was an emergency petition, but physical injury had not yet occurred?
So regardless of the level of physical injury, this is very specific to a suicide attempt. It was determined that there was an actual suicide attempt. So this is just
Right.
visits to the emergency room
Right.
for that reason. All the other variables you're asking about, that's the only data point that's reflected in these slides.
Right, so I just wanted to make sure it included the whole scope, and it wasn't. Right, so what you're saying is
Attempt of any kind, by
Yes.
any means, but identified as an actual
Yes.
attempt by the medical
Okay.
professionals.
Thank you for that. And I note that, you know, in terms of the data showing the increases and particular demographics and age, what, if anything, were you able to discern regarding causality or availability of particular things, like, for example, availability of a weapon, a firearm in particular, as being more significant in those instances where there have been increases?
Yeah, so unfortunately, we don't have a cross-section or overlap between this data and the firearm-related data that we do have that is more robust on the Maryland dashboard in general around firearm-related injuries and fatalities and those kinds of things. So that is exactly the kind of information that we are looking for to being able to look at, again, unfortunately in a post-mortem analysis, but through that Suicide Fatality Review Board. We obviously do know nationally that firearms are connected to over half the suicides that are completed across the country.
Okay, thank you, because I know, yes, obviously that would inform the intervention-related work that is done to help prevent. In terms of the survey that's being done on Black Health, will there be any information shared with the folks who participate at the forums, et cetera, related to advanced directives at all? Because one of the things I think is really important, especially when you're able to engage, is to empower those you're engaging with about their healthcare decision making, and that is one more step, additional step for people to help take control of their own healthcare needs.
That is a great call out for us to include some information about that. That is something that I am really passionate about, and it's often not talked about in the Black community. So thank you for the flag. We will see how we can add that in.
Awesome. Well, and thank you for the flag on the alcohol warning for this weekend's weather. I also, as I doodled down and I went, keep the food inside. Everybody, please, because that's another, we don't need more ER visits related to that either. With respect to the Local Health Improvement Coalition, and I'm going back to the way back to the beginning, I saw that there was the handbook, the Mobilizing for Action. My handwriting's terrible. Mobilizing for Action user handbook. Is that Montgomery County specific or more broad? And then also, is there something, because I agree, I think it's great to have term membership because you need fresh perspective and fresh input, but then wondering if there is something to help the new folks when they come on to onboard for MoCo specific things, since the remaining folks who participate are also those who carry over year to year.
So the Mobilizing for Action through Planning and Partnership is a framework, national framework that can be used, and we have taken that and adopted it to Montgomery County. So that is kind of the chassis that we build our CHIP up. Members are on for 3 years, so they're able to get kind of see it through the whole process.
The cycle.
Yeah, and
Great.
I would give kudos to Elizabeth Beck, who helps to onboard all of our new members. She does a great job of making sure that folks understand what they're getting into. And many of the folks who are term members have been term members for several rounds of CHIPs.
And is there a term limit?
So I believe it is
2 terms?
2 terms,
Okay.
so they're allowed to be around for several cycles.
Super. Random question, but Sean, I noted the Lone Star tick sounds like not from around here. How many of them, how prevalent is that here? Because that was a new one for me.
I'll have to look at the data, but this one is the one that transmits alpha-gal syndrome, which is the one that sounds quite scary because it can cause an allergic reaction where people become very ill when they eat red meat.
Or dairy. It said dairy.
Or dairy, yeah.
Yeah.
And so it is not common, fortunately, at this point. But I can look up some numbers to see what we have. But the deer tick is by far the more prevalent disease-carrying tick.
Yeah, and I'm assuming doxycycline is still the prevalent, you have the tick bite, you're concerned about Lyme, they give you a prophylactic course of doxycycline just in case to make sure we don't get the bullseye and we don't have other disease development, correct?
Yeah, I would say contact your medical provider and they will sort of try to rule out if there's any other things that it might be. But yes, if you're concerned about Lyme disease, about a tick bite, preventative treatment can help prevent much more serious long-term illnesses.
Okay. And last but not least, certainly near and dear to me, Ms. Martin, I wanted to give you an opportunity to talk about on the overdose prevention in Pillar 3, and particularly with respect to juveniles and or their families who may come in contact with the court system, to talk about the folks that are working at the courthouse to do on-site assessments.
Yeah, so earlier this year, DJS coordinated having private providers available at the courthouse so that youth and families, while they're at the court, are able to immediately get an assessment and an intake for substance use treatment specifically. That dropped off, and so at HHS we stepped in with our child and adolescent assessment services team, going to at least do that assessment and referral to treatment. That is on a team that can take on the ongoing treatment, but
Right.
they can do the substance use screening, the mental health screening. It's a behavioral health assessment by a licensed clinician, and then connect individuals to care. I just want to clarify, we are not on site every day right now. I just want to make sure.
Yes.
And that's partly because the overall volume of youth exiting a particular court engagement over to, our team is busy. And so they are there at, they're 11 minutes down the road at Picard. We do have someone that is actually sitting there on Fridays right now. And we're looking for a way to continue to have someone sitting there and making sure that any time that's not used at the courthouse is used in another capacity through telehealth. We're just working all of that out logistically.
Great, thank you.
Thank you. Next, Councilmember Kristen Mink.
Thank you, Madam President, and thank you all for a very comprehensive presentation. I wanted to dive a little bit more into the Medicaid eligibility questions. So I know that the state is leading on a lot of this work. So within that, we are limited in terms of what exactly we can do in terms of following what the state does. One question, which is a very timely one, is around the final rule for state implementation that was published at the beginning of June. And as of yesterday, Maryland is one of 25 states suing the Trump administration, arguing that CMS went beyond the law by requiring people with serious health conditions, so this is the medical frailty question, to prove that their condition significantly impairs their ability to meet work requirements, which of course is not best practices for how we would want to think about medical frailty. And so we have very limited time before implementation of this is going to get started. And now we're dealing with two very different scenarios here. Could you talk a little bit about how you see the state responding and how the county can respond, given that now there's kind of two really different paths in front? It was hard enough, right, with just the one path. Now we have two paths to think about. And I know that there's only been one day before since the lawsuit. We're thinking about that now. That'd be helpful.
One thing that I'll say in general is that the state has been very successful when it has pushed back against the Trump administration in these types of lawsuits. And when they've pushed back, there was a lawsuit last year that halted a bunch of CDC money. Maryland pushed back. We continue to get our funds while that lawsuit was working its way through the process. We ultimately won. And so, I hope that they will be successful in this again. I haven't seen the ruling. It just came out yesterday. But, I think what we have found is that when states push back, they are successful. And so, we are continuing to work with them on kind of figuring out what the rules are. But a lot of it is, dictated to us by the state. So I think our role is really like protecting that safety net and who's going to fall through. But in terms of the regulation and how that comes through, we really am very much dependent on the state and federal government.
Thank you. One of the options that people have for retaining their Medicaid coverage is the 80 hours of, there's work hours and there's also the volunteer hours. So that seems like an area where we could potentially lean in, make sure that we're expanding our volunteer opportunities and that folks are being linked up with that. So if they're able to work, as they're pursuing their work searches, et cetera, that we're making sure that they maintain coverage through volunteer work. Is that something that we are leaning into as a county?
So we are, and we've worked with Work Towards Montgomery, and the county is looking at other options. But I also want to make sure that folks understand that there's a misperception that folks are not working or not volunteering. And when you look at where work requirements have been implemented in other places, the people who lost their Medicaid coverage, it was not because they weren't working. It was usually because of some technical glitch that kept them from being able to show that they were working. And so we anticipate that most of the folks are already volunteering, are already caring for children, are already working probably 2 jobs. And we want to make it easy for them to be able to show that they are doing that. What the state is looking at least for the first year, is a self-declaration that you are working and volunteering while they figure out the technical systems to make it as easy as possible for people to show that they are meeting those requirements.
Are there ways for us I guess goes into our staffing question. So you did mention very diplomatically that neither the state nor the county has really, and obviously we have budgetary constraints, but as we think about the needs versus the budget moving through this year and then into next year, do you have an estimate of what we would ideally be staffing at in order to better meet the needs of this moment? For this first year or 2 of implementation, and then moving forward for a couple years following?
There was a budget proposal in the previous session for 7 additional eligibility workers that didn't go through. That was, we still think that would be helpful. There is work that can be done on the volunteer side to help notify and educate the community, but they can't help process applications. And so there really is the work on helping to make sure that people are processing applications without errors and all of that.
Thank you. How much of the balance would you say is between like outreach and education to the public versus on the processing side for us?
That it's a both and, right? So when you think about the processing side, the workload is doubled. You have to process more information twice as fast. And so you think about, the doubling of workload on those individuals, on those eligibility workers. And, how much are people just don't know, aren't falling through the cracks. I think there is also a lot of education that will happen on the healthcare clinic side, because people will probably not know that they have lost their coverage until they show up at the doctor's office for a visit and then learn that their coverage has been dropped. And so we are also working really closely with Montgomery Cares and PCC to help the clinics understand what's happening so that they can do some proactive outreach to their clients to say, hey, look, you're going to expire in 6 months. What are you doing to get renewed?
Great, thank you. Also, in the category of things we didn't fund in the budget, the Babies Born Healthy, we have 1.5 FTEs there that had been on a grant before that are now not funded. That's a gap that's going to directly impact, if we don't find a way to address that quickly, that's going to directly impact people who are receiving services right now. Can you talk a little bit about that?
I mean, certainly as a county, we've identified, Montgomery County is no different from the state or the country in that we have a Black maternal health gap. And so Babies Born Healthy is really part of the solution in addressing that gap in Black maternal health outcomes. And, we continue to be supportive of the program, and, having that additional staff allows us to reach more people.
Thank you. I'll just flag that. I think that's something we need to come back to really quickly. I think that was just kind of a miss by us, that we need to make sure we're not dropping coverage here from people who were receiving it, which is what would be the outcome if we don't deal with this quickly. So thank you. And then lastly, and then I'll hand it back to the Council President. I just wanted to hand it over to Dr. Martin, because we've had a number of cases that we've seen now related to evictions of people who are experiencing mental health crises or who have ongoing mental health challenges. And, the Crisis Center has been very responsive, and MCOT has spent a lot of time with even just, single individuals. But it's certainly, we've had a number of those within my district. I have to assume that they're elsewhere as well. But could you talk a little bit about how that impacts, the work of MCOTS and kind of what you're observing related to that?
Yeah, no, as you said, it is common occurrence, as it would be for any of us, that anyone who's evicted from their home is in distress and emotional distress in that moment. So layering on individuals who may already have had behavioral health vulnerabilities to begin with. It is a moment of crisis and one that we are commonly attending to, right? Not every single eviction, but commonly attending to. So, and the important thing to be mindful of, as I know you in your office and your staff, and you have been as well, is that someone can be in acute behavioral health distress. They can be quite mentally ill and not be a danger to themselves or others. And I share that because there's, out of great intent and a lot of love, folks are often wondering, why someone may be petitioned or not be petitioned. Obviously, they have to meet medical criteria for that determination. And in situations, for example, where perhaps a neighbor or a loved one or someone is physically staying, very close to or in front of the location they've just been evicted from for a period of time, there's a lot of community concern, and that is a concern we all share. So again, MCOT is available for any crisis. We don't define what the crisis is. The resident defines it at any time. We've had multiple situations, not just in eviction scenarios, but others where our team is engaging and going back the next day and going back the next day and going back the next day and just doing follow-up in the next shift for various reasons. Impact, and we work very closely with Chief Hong and her team at Services to End and Prevent Homelessness and all the community outreach partners that work with her in the nonprofit sector to just circle back around, try again, try a different strategy, and we really, really value greatly the support of the community in providing any information that they have in scenarios like that can help us hopefully provide the best path to safety and hopefully support beyond that.
Thank you so much. And I just want to give huge credit to you and your team, as well as to Seth, who are doing this type of work all of the time. And, we don't always see it, but I have had the opportunity, to see it up close a number of times. And obviously we want to reduce the more we can reduce those happenings, the better. And that's something that, we've greatly reduce the number of evictions that are actually happening, which is, of course, that's the number one goal. The more that we can back up, the earlier those interventions can happen and we can prevent those crises at the last minute, the better. And that's what we've been doing. But we have to have somebody to call in those moments. And so I appreciate the work of your team as well as of Seth on those. Thank you. As well as the community has been amazing. Thank you. Yield.
Thank you for that. Before I turn it to Councilmember Katz, I just want to share very good breaking news, because we all need it. The Supreme Court just decided in the 5-4 vote that they rejected President Donald Trump's executive order declaring that children born to people who are not in the U.S. Legally, that they are U.S. citizens. So that's good news. So they have, they upheld the birthright citizenship. Okay, so with that, I know 5-4. Councilmember Katz, you're next.
First of all, it's unbelievable it's 5-4. First off, as we begin, I just wanted to take a second and tell my friend and President Fanny Gonzalez that every person appreciates the horrible time you're going through, you and your family, and you're not alone. We're all here. And I think it was most appropriate that Councilmember Jawando handed you the tissues. First of all, it's appropriate that they're near him, but he and I have cried many times over topics over the years, and he certainly knows exactly what I'm talking about. And to Dr. Davis and your entire team, thank you for the updates and all that you do. I say all the time that we take for granted the great things that are done in Montgomery County, especially when it comes to health. And every person believes many times that it's done by magic. And I say that about, I said that the other night when at the graduation that Councilmember Luke and I attended for the Fire and Rescue Service, and I say it all the time, but thank you for what you do. For the whole thing about Medicaid, that they have to re-up every 6 months and all of that type of thing, is there a nonprofit or a community organization that will be so knowledgeable that someone can help them, a person, navigate that system? I mean, it's going to be very, very confusing. It's confusing to somebody that has a PhD. It's certainly going to be confusing to somebody that's out there struggling in many ways. So is there something that can be, what we can work with, a group that we can work with to help that?
Really, it's a lot of groups. So Maryland Health Connection, which did that's the group that when Medicaid was being rolled back the first time around, did a lot of the education for the community. There's a whole toolkit that the state has partnered with the MCOs and hospital partners and many different organizations to do that campaign. There'll be social media, they'll be on the radio, and they're doing a lot of train the trainers. And so that is essentially what the symposium in August will be for our local community, to really train the trainers on that toolkit on how they can kind of work with the community to walk them through that process.
Okay. Thank you. And for the whole idea of the Narcan kiosks, and I applaud it and I'm glad, have we thought about whether or not, and I appreciate the early rollouts, but have we thought about putting them in libraries, putting them in places where the public would be there anyhow and not necessarily just going for that purpose?
Yes, we've definitely had conversations about that and exploring expanding those partnerships to ensure that everyone has access to Narcan from any possible place. So we've explored libraries. We also had conversations with recreation as well, just looking at opportunities to put it in places where, just like you said, everyone will automatically be.
Good. And the whole idea for suicides, I mean, horrible situation. Someone calls 911 to get their loved one to a hospital, and that, just like the whole idea for Medicaid, when someone believes that, well, I'm taking it away from a person, you're not taking it away from a person, you're taking it from a community, because it ties up that emergency room, it ties up. And then we have to, and I'm certainly someone that absolutely applauds that we don't arrest someone who is in need of who has an overdose or whatnot, but we need to make certain that that person gets help. And that's always been a concern of mine. I have heard, anecdotally, that there have been times with 2 and 3 times in a week someone has overdosed. Well, that person, I don't believe we should arrest them, but I believe that person needs to get help so that we can help them not have that situation for whatever it takes. So, and for the whole idea for intimate partners, the violence, it's important to remember that Montgomery County perhaps is the best in Maryland. It is the best in Maryland, or the nation, with their Family Justice Center. We did it early on. Someone is a one-stop shop, and everyone has to remember that they're not alone either. That when this horrible situation occurs, that they have partners in Montgomery County that are willing to help them and get things accomplished. And for the whole idea for PFAS. First of all, I didn't know what PFAS was until your town hall meeting. I figured, what in the... And Councilmember Balcom and I attended it. You all did a great job. You did. There was a lot of information given. There was, there's concern. The fact that our drinking water is safe automatically stops a lot of people from, it's not going to affect me. I'm not fishing in the muddy branch. It is affecting us, and thank goodness you all are. And all of our partners, WSSC and the state of Maryland, all of us are working to help straighten that concern out. The fact that it's been like 10 years since Montgomery County Fire and Rescue used that foam, and it's taken all this time for it to be a concern, or I guess it was a concern all along, but it's been 10 years. So this is something that really is a concern. And then I applaud the whole idea for urgent care work and the state of Black Health Survey and all of that. We need to know what we need to know, and that's exactly where we are. And for the whole idea from the mobile health clinics, I'm not surprised that we're at the max. And I know that not everyone can come to us, so we need to go to them. But I don't believe that I believe we're going to need to continue to increase our max, because it's only going to get more and more people, especially, and the whole idea that if someone doesn't have health care, that's just going to stop that person. That person is in our community. We need to make certain that that person gets healthy and that our community continues to get healthy. And on the last thing, Council President, you were talking about the DUIs. I went, I don't know, last week, 2 weeks ago, whatever, you get enough events. They have a court graduation for DUIs in Montgomery County, and you are right that there was several people who have gone through an extensive program to get themselves back on track. And to each person, they realized what a problem they had caused and wanted to straighten that out. So there's, through the law enforcement and every other agency, we're all working on that. Thank you all for everything you do. I yield back.
Thank you very much. Next, we have Councilmember Will Jawando.
Thank you, Madam President. Thank you for the presentation and all the work. A lot going on, a lot of challenges, but also a lot of opportunities. I just wanted to be additive and ask about a couple things. So how are we doing with the ER capacity issues? And how do we think, and what's the planning going? And I know we have someone from Holy Cross. I don't know if she's still on, but okay, she probably had to drop to deal with the ER capacity issues or whatever. But how are we thinking or projecting or working with them to deal with what will be more uncompensated care come October and later in the year, and just how we're anticipating those two things interplay?
So I think when we think about ER wait times, there's really kind of three buckets. There's how do you keep people out of the ER? So they're not there clogging up the system if they don't need to be, and that's really working on primary care, urgent care, prevention. There's the hospital itself, so how people move within the hospital. So is the hospital well enough staffed so that people, once they get admitted, that they can then get to the beds, ICU beds, the regular beds, and then there's the discharge out of the hospital or out of the emergency room. So do people have a place to go that need to be when it's time for discharge? And so from the health department perspective, we work on the how do we keep people out of the ER, and then how do we make sure that there's systems in place when they come out. And so some of the collaborations you can think of, the respite beds for homeless that we've partnered with Nexus Montgomery to create. There are also things that are happening with the AHEAD model and population health plans that are in the process that we are creating and collaborating on those right now. I don't think there's nothing new to release or say about that work other than it is ongoing. I know that I think it was last year, Maryland had the state had a kind of work group and plan on addressing this, and the hospitals are in the process of kind of rolling out their plans on how they are addressing hospital wait times. But from a county perspective, it's really about how we strengthen the safety net on both sides, the input and the discharge.
Yeah, and and I know you're in touch with them, I'm just thinking of, because we expect to see people drop off Medicaid, and how we're working with them in real time to try to catch more of those people, like you talked about on the front end. We're not going to be able to get everybody, and then obviously how we're getting people signed back up, and all the things you talk about are part of that, reducing that. I'm just worried about the pressure it's going to create on the whole system, as I know you are as well. Just double tap the maternal health disparities in babies born healthy. I was at a program, I think, with you and Dr. Ashford recently at Holy Cross, where we were talking with families, and it's an amazing program that there's never enough of it, and so we need to figure that out. On the DUIs and the substance use and the overdose, a couple years ago we had an interaction where I pointed out that like 100% of the DUIs, is the overdoses, and I think we're at 70% this year, but 100% a couple years ago were Latino men, or were all men, and I think the majority of them were Latino men. What are we doing specifically? And you could put this in the same category as the suicide rates for Black and men and Latino men in general, which are increasing. What are we doing specifically as far as strategies to address either programming strategies to help address what is clearly a troubling trend?
Yeah, so one strategy we implemented was a community awareness campaign focusing on African American males and Latino males, specifically because of the high rates of overdoses in those populations, just to try to encourage reducing stigma, encouraging getting connected to programs and services, but also educating around overdose strategies as far as like, having Narcan in place just in case you decide to use, or having a preventative plan and things like that. We're also been doing a lot of outreach in those populations, working with like the African American Health Program and other programs, the Latino Health Initiative, to try to reach those various populations in regards to getting naloxone out in the community, dispensing fentanyl test strips in the community, xylazine test strips as well. Just really trying to increase awareness amongst those populations to try to, one, saturate the community with Narcan, but also try to get persons that are struggling with substance use connected to services and programs like treatment and things like that too. So I think it's been like an all hands on deck type of approach, working collaboratively with partners, because as far as our team in harm reduction, so like three or four of us, and so it's definitely a collaboration working with community-based organizations and others to try to reach those populations.
So it sits in harm reduction. I just think we need to have, and this will be an ongoing conversation, use some research-based, things that we are tracking. Raising awareness is one thing, but I would be very curious to know how successful has that outreach been? Who are we talking to? Have we seen what providers are we working with that are interfacing with? Because these numbers come from somewhere. These are people who have been in a system for this, and that's only scratching the surface. There's many others that aren't. So I think we need to really, I'm very curious to work more on this among these issues. Go ahead. Yes.
You saw my finger approaching the mic. I'm sorry. I just wanted to add that we are also talking to community partners about doing mental health first aid training specifically for the Black population and for the Latino population in Montgomery County as one strategy that's catered towards addressing silence and men's health as well. So again, targeting in that way. Had a meeting already, of course, with the Latino Health Initiative around the suicide spike, and we do have some funds available to do targeted communications and outreach there. I don't know if you're aware, LHI shared with me that when it comes to our Latino population, there was a study they had done a year or two ago, and it turns out that our Latino men in the county, the way that they're getting most of their information is on Instagram in English, not Spanish so much, whereas the ladies, it's on YouTube. That was a big surprise, on YouTube, not a different vehicle or WhatsApp. So using some of that information and research to, again, do communications, outreach, also trainings. There will be a larger plan. We are kind of working through kind of how to target it, again, not just from a racial and ethnic standpoint, but also demographic, as Councilmember Evans pointed out, to get into some communities and work with trusted brokers and partners to do that work.
That's great to hear, and I'm a big proponent of, not everyone needs the same strategy. You have to look at how you reach people, what strategies. It's one of the reasons the Commission on Women is so important. So important. I think we also need a commission on men and boys. There's different strategies that work to reach people in different ways. Last thing I'll ask about is just the MCOT, since I'll stay with you. What's the capacity? I've been on these ride-alongs, and it's a great program. Years ago, we wanted to shift with the idea that we would be able to divert 911 calls, and so that that are non-violent responses to more trained professionals. Just where are we now as far as the capacity and how you think that's going and where we need to go?
We're in a much better place, and I really have to commend Dornay Hill, our Senior Administrator for Crisis Intake and Trauma Services, Beth Tabachnik, our Manager of the Crisis Center, all the supervisory therapists, and all the clinicians themselves, because they have experienced so much growth and so much change so quickly. Change is constantly coming at them in our efforts to make sure that we're using this service in the best way possible for our community. So going into this next fiscal year, 2027, we'll be able to have up to eight MCOT teams available during our peak volume times of 7 a.m. to about 11 p.m. Monday through Friday. That's Monday through Friday because that's just when the calls come in. That's when we have the greatest number of calls in general. We are also establishing another location where an MCOTS could dispatch out of. I think I shared previously in crisis updates that we have a team always, again, during those peak volume times, stationed in Germantown at the Upper County Regional Services Center. We have one at Georgia Avenue in Silver Spring. We have 4 to 5 teams in Picard, and then we have a team that's been in partnership with the City of Tacoma Park in the Tacoma Park city offices as well. We are having a clinician assigned to the City of Rockville that was co-responding in the City of Rockville. That's been a partnership that's been in place for a few years. But the city, in their budget deliberations, they made a change going to fiscal year 2027. But then that's one of the reasons why we are going to start having a team dispatch out of just further south in Rockville Pike, because, Picard is, our crisis center is up in Goody's, pretty northern Rockville, so this would be at our 1401 Rockville Pike location. It's closer to the Neville Street shelter, and we have a high rate of calls in that area in the 20852 zip code as well. But I think even more importantly, we've ramped up radio training. We have an energized, to me it's exciting, excited group of newer professionals that have joined this team with the expansion. And so the energy is positive, it's robust. We also have a draft MOU across 988 911 in our crisis center that is undergoing legal review for some different triage opportunities there. And then we're also have had some planning meetings related to having the 911 Emergency Communications Center be able to directly dispatch and use the CAD system for the teams. But again, all of this is in development, and we welcome any input at any time.
Exciting to hear. I think that's where we need to ultimately head, and it sounds like we're heading in that direction. So thank you. Thank you, Madam President.
Thank you. Next, Councilmember Kate Stewart.
Thank you. Thank you for the presentation and all the work. And I'll just pick up where Councilmember Jawanda left off. And Chief Martin, thank you for all the work with the MCOTS. And I'm thrilled to see especially the partnership with Tacoma Park moving forward, as that I know has been many years in the working, and I know the city is very happy with that. In terms of the intimate partner violence that you highlighted, one of the things that we're hearing from some of our residents and some of the nonprofits is from particular community groups, a rise in intimate partner violence. And I do want to agree with Councilmember Katz, the work of the Family Justice Center and all of your work. But similar to what you all presented before in seeing in specific communities a rise in mental health issues and other issues because of the current climate we're living in. Is there anything specific from you all on the intimate partner violence that we could share more with communities that may be under additional stress at this time and may be experiencing increased rates of intimate partner violence?
Yeah, absolutely. Thank you for asking. I didn't speak to the chart that was on the right in that particular slide because I was being mindful of time, but of course the ongoing trend is that females, Hispanics, and non-Hispanic Black residents in our county continue to have the highest rates of intimate partner related ER visits compared to our non-Hispanic, White, and Asian Pacific Islanders. And those disparities mirror our client population, absolutely. Communities of color continue to represent a significant portion of survivors seeking services. And for us, it really reinforces what we're already doing, but to be doing even more of and really get to deliver to a greater expert level, culturally responsive services, of course, multilingual advocacy, language access, and community outreach to underserved populations. You know, it's every kind of social safety net, behavioral health net's kind of quandary is, you know, you're responding to crisis and emergency, and you've got the same team available to do kind of that really acute expert outreach in the community. So we're so lucky to have the Family Justice Center and to have the Victim Services Advisory Board that helps us with that outreach and that communication. And I think the most important thing to share to our community and our communities that are suffering in silence with this dynamic, is that what you are going through right now, you are still absolutely protected under federal and local law in reaching out and seeking help and getting confidential, private support as you need it, including emergency shelter. And it's at an undisclosed location, and it is something that our public safety partners and all of our community-based nonprofit organizations that communicate this work, and certainly HHS and the Family Justice Center, take incredibly seriously, because we know we're talking about your lives, we're talking about your residents here in the United States in many reasons. We're talking about staying connected to your children, all kinds of things. But despite everything that is happening in the federal climate, you have protections. VAWA is still very much in place. And so please reach out so that we can support you.
Thank you. And on the mobile health clinic, just thank you so much for that work. Our office continues to make sure our residents, particularly in the Long Branch area at the Clifton Baptist Church, know about it and send that out. And I agree also with Councilmember Katz that given everything else you have told us and what we are seeing, that is going to be a vital part of the services we provide. So just thank you for that. I did have a question in Germantown on the moving of the ER, and this goes back to my experience when the hospital moved out of Tacoma Park. And it's the work you're doing. I'm very thankful for the $2 million and all that work, that there's a comprehensive plan. That wasn't there when we lost the hospital, and I'm glad it's here for this. But one of the things is with ERs, right, they have to follow EMTALA, so they can't turn someone away. And urgent care, primary, they're not under that same mandate. And so how are we, with people losing insurance and all of this, how are we balancing that and thinking about losing the emergency care there? And yes, it would be great to funnel people into urgent care and other things, but what if they can't pay for that?
You're right. It's still a concern, and it doesn't meet all of the needs. And urgent cares and Montgomery Cares and our clinics are not subject to EMTALA. They don't have to take everybody that walks in through the door. We're trying to make it as easy as possible and looking at, eligibility. How do we make sure that, maybe somebody, often a client will obtain their Montgomery Cares coverage by first showing up at a clinic. And so we are still working out, could that be because they showed up at an urgent care clinic? Does that give them, is that a way to get them enrolled in Montgomery Cares? Honestly, we haven't figured out kind of that administrative process yet. We know that many of the folks from the Germantown Emergency Center will end up at Holy Cross Germantown and Adventist, but we know that there's a gap, and we've been in communication with Fire and Rescue, who's also very concerned about emergency room wait times and where they're going to transport people from the ambulances. So we recognize the gap, the concern, and making sure that folks end up where they need to be.
Great. Thank you so much. And then Dr. Davis, you did ask us to sort of say, as you're moving forward in your work, prioritizing, and as everyone was talking and you all were presenting, I think it's, prioritizing the people the most in need, those who are going to just lose coverage, as you said, first off, are refugees, and thinking about, as we're looking at suicidal fatalities and the rise in there, where is the most need, and then the process, which is for the folks who are, as Councilmember Mink said, not, losing that coverage, but, can reapply and get that, because what we don't want to have happen is people just get discouraged and just then not do that. So I would see those as priorities. And then my final question is, and again, thank you so much for all the work across the board. In other areas that, in addition to members of our community who are basically under attack by the federal administration, we also have specific types of medical care that are under attack, gender affirming care, reproductive health care. How are we in the county thinking about that type of medical care and how we can help our communities who need that care?
Our commitment remains strong to making sure the LGBTQ community has access to care And at the same time, we know that our clinics have struggled in that area. CCI had planned a large expansion, and because of the changes in Medicaid and Medicare, they weren't able to do that expansion to increase their LGBTQ services. We work with the Pride Center, congratulate them on a very successful Pride weekend just this past Sunday. But we are trying again to make sure that folks have those resources in the county. We have not seen another clinic that has stood up to raise their hand to try and provide those services. We do allow through our syringe services program that we use for substance use. People are also able to use, access syringes for hormones if they need to do so. But we recognize that there are still gaps there that we are looking to partner with folks to fill.
Thank you. And so in terms of priorities, I would add that as continuing that work, and just want to, again, thank you all for all the work you do, and not just the presentation today, but all year round. Thank you very much.
Thank you. Next, Council Vice President Malcolm.
Thank you. This was, of course, an excellent presentation, as we do that whenever you come. Just a few things. On PFAS, I just really appreciate the coordination between the Office of Health and Department of Environmental Protection. This really should be the model for how we communicate emergencies to our community. It was fast, it was inclusive, provided a lot of opportunities for the community to ask questions. And so I really wanted to uplift that, as Councilmember Katz mentioned. It really was an excellent community meeting, and I appreciate everybody's work on that. I do want to lift up the issue of well testing. So there is free well testing during this emergency for anybody in this specific area. Very important. There aren't a lot of wells in the area, but it is important. But it really brings, from a long-term perspective, it brings in the issue of how we can support our vast community who are on well water. The town of Poolesville tested positive in their water system for PFAS, but we have a lot of individual wells, and we do need to come up with some comprehensive system for testing, particularly drinking water for wells and PFAS. So that's something that I think that I would like the county to come up with some way to do that. I don't know if you have thoughts about comprehensive treatment or testing for well water.
I would just add that the state and the county both agree that well water, if it's being used for drinking, should be tested annually. The recommendations also to test for PFAS. We suspect that a large number of people are not testing their wells annually. We suspect they're not testing for PFAS, but from a public health perspective, we strongly encourage that.
Thank you. And I've had some brief conversations with WSSC about, and a couple, of course, the town of Poolesville, about how we can educate the community and also provide some funding for testing, because I think that's certainly not the obstacle for everyone. I think people just don't test because it's just one more thing they've got to do. But I do think that cost can be an obstacle for some people out in our rural communities. So thank you. We can talk further on that. Just want to say thank you for the mobile health clinic, particularly the way that you all work very closely with the community, and the community is a full partner in the mobile health clinic, and you don't just come in there assuming that you're the expert. You really work very closely with the community. I appreciate that. And then the other thing I just wanted to mention, several people mentioned the closure of the Shady Grove emergency room in Germantown, and we've already have the ER capacity issue. But I did want to talk about the role that the Holy Cross is playing. It's been mentioned in regard to the overall emergency room capacity, but they have really worked closely with Shady Grove in Germantown to make sure that the transition that happens, that the community knows that the emergency room's closed, but the emergency room at Holy Cross is open, functioning, and they understand that their influx is going to go up significantly. So just wanted to mention that. And that's it. Thanks.
Thank you very much. And I don't see anybody else wanting to speak. With that,
Excuse me, Councilmember Bonnie Gonzalez. I'd like to.
Oh, I see. Go ahead.
Oh,
Go ahead,
great.
Councilmember Sales.
Thank you, Madam President, and my sympathies with you and the Venezuelans mourning losses across the world. So thank you, Dr. Davis and your team, as always, for the comprehensive updates that you have provided, and all of the work you and your team continue to provide to improve the health and wellness and outcomes of Montgomery County's residents. As chair of Health and Human Services, I appreciate these briefings because they keep us informed and help guide the work that we do. I was looking back at some of the previous updates and presentations that we have received, and left with more questions than answers about how we are measuring our progress over time. And so I think in the future, these discussions may be even more valuable if they answered some questions. What did you tell us the last time? What has changed since then? And what do you need from the council? So if you're able to begin each briefing with a brief progress update to ensure that we are able to track and monitor these discussions, would that be possible?
Yeah, thank you. That's really helpful feedback that we can take into account in preparing for October. So leave that in for next time.
Thank you, thank you. And I do have a few questions since our last briefing. I know my colleagues have asked about the Board of Health update. You discussed the last time maternal health, behavioral health, strengthening community partnerships, and expanding access to care. Just thinking about the past 6 months, are you tracking any progress, any measurable progress on those issues since the last briefing? I know that the Community Health Improvement Plan dashboard's coming in the fall, but just want to know what key indicators the Board of Health should be watching to determine if we're improving health outcomes and making progress in these areas.
So most of the data that we're tracking comes on an annual basis, so there aren't many hard updates in that regard to share. We did have our annual maternal health update just a couple weeks ago. The FEMR CAT team shared their information. There wasn't any significant changes than what we saw before. I think the one thing that was notable from that presentation was that Maryland has gone 5 years without an infant-related death in a hot car, and last year we had 2. So as we are coming up on the impending heat this weekend, I remind folks to not leave kids or adults or pets or anybody in a car for any period of time. It gets really hot quickly. One of the things that I will say, in terms of previews of coming attractions for October, some of the things that we've been looking into around maternal health, we're currently going through a restructure of maternal health team, so we'll be able to provide some updates on that. We've been doing some investigation in birth centers. We had a call with, or we were supposed to have a call with Roots out in Minneapolis that was had to be postponed, working with Community of Hope in DC. So working on a memo around some of the barriers to birth centers in Maryland and Montgomery County. So just some previews of coming attractions on things that I know that you care about that aren't quite ready for this presentation, but we hope to have across the finish line by October.
All right, thank you. You also showed growing disparities among Black and Hispanic residents regarding suicide rates. Given that this is the first State of Black Health survey in approximately 5 years, I know that someone asked about the partnerships. How are you using the survey and our community partnerships to ensure that we are reaching as many residents as possible with regards to socioeconomic status, zip code, just to ensure that we are actually going to be able to translate this information and the findings into measurable outcomes over time? Just wanted to.
Sure, we are working with our partners across the county, so with Frederick Hawkins and in the Office of Community Partnerships, but not just with the African American liaison, but also with the African and Caribbean liaison. We are working with the faith community. We will have a targeted focus group specifically for faith communities, targeted focus group with healthcare communities. We are working with the African American Health Program, with the Black Physicians Healthcare Network, and really with community partners to get the word out. We appreciate if you guys would include it in your newsletters. We're happy to send a flyer as you send things out to the community, working with our Divine Nine partners, and really trying to get the word out broadly. So we encourage you to help us spread the word as we try and get it out to everybody. There was a lot of spreading the word at Juneteenth celebrations that happened last weekend as well.
And since it's been released, how many people have taken advantage of the survey? And are you sharing this on HHS's social media now that we know that's where a lot of our residents are receiving information?
It has been shared on social media. I don't know the counts on how many people have filled it out so far.
Okay. And what is the deadline for responding? I don't think that was answered earlier.
We don't have a hard deadline. We have a soft deadline of middle of July, but we will also be looking at responses, and if they're low, can extend that.
Okay, perfect. I'm glad to see that we are hosting a Medicaid symposium in the fall, in addition to other planning efforts, with more residents becoming uninsured and underinsured. Are there any policy or budgetary decisions that you want the council to be considering in anticipation of these cuts?
I think the county and the council is really going to need to think hard about what investments we make for the safety net for this population of folks that's about to lose their insurance. You know, as I mentioned, the budget for Montgomery Cares covers 78,000 visits, which of the current population is about 2.4 visits a year. If we expand that, does that mean, do we expand the budget? Do we find cuts other places? Do we institute wait lists? Do we limit the number of visits? Those are all hard questions that we as a county and a council and Department of Health are going to need to wrestle with on how we think about this safety net, right? Those, as we just went through a really hard budget season, we know that pie is not limitless. And so how we think about using those funds to support the most vulnerable is going to be really important.
Okay, thank you. And then given the relationship between the intimate partner violence, trauma, suicide risk, how are these efforts or the work being integrated across the county's behavioral health and public safety system? And I don't know if Director Martin wants to take this one.
Yeah, absolutely. In terms of the behavioral health crisis piece of the work, We meet on a very regular basis with our public safety partners. I myself have a monthly meeting with the Captain McFarland and Lieutenant Cox, who oversee the Crisis Resources Division, and that includes our Crisis Center management team. But on a much more regular basis, our Crisis Center manager and our supervisory therapist that oversees all those that are co-responding with public safety, all the clinicians that do that specific work. I mean, they're talking on the daily, of course, with the Crisis Resources Division, as well as different district officers and command about particular incidents in their community. We continue to have the Behavioral Health Coordinated Systems of Crisis Care work groups, one that is focused on the integrated crisis call centers. So that's the work group across 988, 911, and our crisis center. The Crisis Center call line. We have one that is focused on mobile crisis outreach. And I need to highlight the co-chairs of those work groups because Sarah Rose, our director of a local behavioral health authority, and Ariel Gordon, who oversees the 988 hotline at Everymind, co-chair the Integrated Crisis Call Centers work group. And then we have Avital Graves from Montgomery County Fire and Rescue, and Dornay Hill from our team in the Crisis Center, overseeing the mobile crisis and outreach team work group. So again, it would take me a while. I'm happy to share more information to make sure that you see the roster of all the different community stakeholders and agencies that are involved in those work groups. And then the final one is the one focused on the crisis stabilization facilities. And right now we're very much in just very intense planning mode around the reopening of the Crisis Stabilization Center, the expanded one this fall at Bacard, and ongoing work around the future diversion center facility at the 7 Locks Road in a couple of fiscal years, hopefully, to continue supporting options to divert from the emergency room and from the criminal justice system.
Thank you. And what about the Black Physicians Healthcare Network? Most of the funding that they receive is dedicated to mental health and behavioral health services free of charge. And so just wanted to better understand what that communication pipeline is like.
So they receive funds to help connect clients to a Black physician or healthcare worker, and they are able to connect them to a dentist, to primary care, behavioral health. I think they've had the most success in finding mental health resources, I think because that's where the biggest gap is. But they do connect people up to dental care and primary care as well. I think they were funded at a flat level this year, and they continue to be a great resource in helping to connect people up to care and really to help cover that gap for folks who need services but won't be able to cover it, especially for dental and mental health when traditional insurance may not cover it.
I was following up on Director Martin's question to see if she's regularly engaging with the Black Physicians Healthcare Network, since because of the pandemic and their founding, we realized the mental health crisis was impacting the Black community greatly, and that's why this initiative was started and has continued. And just wanted to see if they are also a part of this regular check-in with Director Martin and the public safety teams and the crisis center as well.
Yeah, in terms of the coordinated crisis system work groups, those are open to the community and anyone, and so Black Physicians Health Network absolutely will make a concerted outreach effort. As our Chief Medical Officer stated, though, with their role in connecting people to care and addressing those gaps in the actual connection, we have very regular connections because all of our clinicians and managers are very well aware that that's a resource for our community. We do a lot of that direct connective work as well, but we absolutely recognize value and lift up the importance of having a culturally specific entity that can support you in connecting those dots.
Thank you. Yes, I think with the numbers directing us to pay a bit more attention to culturally appropriate care, we need to make sure that they are at the table as we're planning and monitoring the situation to ensure that these outcomes and recommendations are culturally appropriate. And so I'll end my questions there. I just want to ensure that, for future briefings, so that this board can make good recommendations in a timely effort of following these presentations, it would be helpful to reiterate. I think you mentioned some questions you wanted us to think about. If there's any specific policy, budget, or legislative actions that we may consider that you also want to share, just to ensure that these are more action-oriented and we are able to track and monitor the progress we're making over time instead of having updates about new topics. So that's just my recommendation, and look forward to the upcoming events in the fall that you've shared.
Thank you very much to the entire HHS team for this biannual update. With that, we're going to move on to agenda item number 2, which is the consent agenda. I will entertain a motion to approve the consent agenda. Moved by Councilmember Will Jowando.
Second.
Second by Councilmember Lori Sales. All those in favor, please raise your hand. And it was approved. Thank you so much. We're going to meet again at 1:30 p.m. Thank you.